Morning, guys.
Morning.
So, can everyone see okay? Can you guys see okay? All right. Okay. So this morning we're going to talk about high frequency oscillation. This is based more on the neonatal side, okay? But some of the application, the principles, it applies to adults as well. High frequency is still high frequency no matter what. So I revised this slide, this presentation in 2012. So I'm hoping to get the feedback from you guys, see what you guys think about the revision from the previous, the ones that some of you guys had a chance to see the previous slide. So what is high frequency? Okay, so high frequency ventilation is a type of mechanical ventilation that employs very high respiratory rates, anything greater than 180 breaths per minute, and very small tidal volumes, anything below anatomical decibels. It's an alternative form of mechanical ventilation and also helps to reduce ventilator-associated lung injuries because you don't have the constant stretching. So let's talk about the history. Okay, the initial concept was started in 1915. Smoke going down a tube, travels in a very thin column. Could you ventilate with only a small volume? That was a question that would arise. Tried in animals from 1975, but results not replicated in human models. Used successfully in neonates and then in pediatrics since 1983, and several small trials in adults since 1999. Another key part of this research is that everyone knows that when a dog pants, okay, they pant, breathe over 100 times a minute. And it's amazing how, they're cruising, they're chilling, okay, and that's what also some of the ideas came about high frequency, because can we breathe, with a small volume, all right. So 3100A ventilator was approved in 1991 for neonatal applications for treatment of all forms of respiratory failure. Approved by the FDA in September 2001 for patients greater than 35 kilos. Okay, so this is our pediatric and our adult populations. And this is the B version. Okay. So let's talk about the different types of high frequency. So we have the up top high frequency oscillation ventilator, what we're going to be talking about today, the 3100A and B. We got the high frequency jet ventilation produced by Bunnell. This was something that they produced in the early 90s. Then there were they had some complications because it was drying out the carina area. So then they needed some revisions, and so now it's a very popular model there. High frequency flow interrupters. Everyone remembers the beautiful infant stars, right? Yeah, great little ventilator. I mean, it had its own applications. Mechanical ventilation, high frequency, back and forth, it's a great vent. But unfortunately, with the flow interrupter, you can't generate the mean air pressure like you can with a high frequency. Okay, that was one of the limitations when the baby's lungs got super stiff, and then we weren't able to ventilate the patients appropriately. So we have to crank up the amplitude and the mean. But then once we put the baby on the high frequency, now because the magnet is so powerful, we were able to wean everything down, and the baby responded better. So this has some limitations, but for your basic, this is a great gun. You get the high frequency positive pressure ventilation. So the Draeger Evita. Okay, so this is something that they're supposed to come out with. So we'll find out. And Draeger's been promising a lot of things to the U.S. market, but hasn't produced. So we'll see what happens in the future. Okay, but this is just the different types of high frequency ventilators out there. All right, so we're in an A and B. Let's talk about that. So number one, we have an active inhalation phase. So what that means is that the piston on the oscillator, okay, is going to push something in. So when something pushes in, it's considered active phase. An active exhalation phase, okay, and so like on the 3100A and B is that when the piston goes forward and when the piston pulls back, that's an active exhalation, okay, because it's pushing air in and pulling air out, the piston mechanism goes. Now with other brands, it's a passive exhalation like the infant star, the flow interrupter, okay, so once the flow is interrupted, then the patient's allowed to passively exhale like when we breathe. We actively breathe in, but when we exhale, the air just flows out naturally, and that's what the infant star does. So the A and B, we were able to better control our mean and our amplitude because we have that consistency with the piston. All right. So before we start with what the high frequency is all about, let's talk about what optimal peak is. Okay, everyone remember what optimal peak is for, right? So, definition of optimal is the most desirable or satisfactory. So if we look at this diagram here, okay, so here's our lungs at 0 peak. It's collapsed. All right? And this is the capillary bed. At peak of 5, okay, we still have, our lungs are still reduced. Over here at peak of 10, now we have the lungs opened up correctly, and we have now we're able to, the oxygen and the CO2 is able to diffuse across the AC membrane. And then at peak of 15, you can see that the alveoli are over-distended. Okay, so this is something that is very, very important, but at the same time we really take it for granted, because when it comes to ventilation and oxygenation, if your lungs are not expanded correctly, then you're fighting an uphill battle. And if you're over-distended to the point where your alveoli are over-distended, now they're going to collapse the capillary blood flow, so you have no perfusion to pick up oxygen. So you're going to have oxygenation issues. So it's that fine line, from here to here, what is optimal, okay? Okay, so optimized lung volumes. So optimal P equals optimal lung expansion. So let's take a look at that, okay? So on this diagram here, this is our inspiratory side and our expiratory side. We want evenness going through, and that's what optimal peak brings us, the opening. So we're not under like this, and we're not over like this. All right. So theories of operations on mean air pressure. So the definition: total amount of positive pressure in the lungs during an active breath. Okay. So positive pressure. So which includes your inspiratory tidal volume, okay, your inspiratory rate, your inspiratory time. Anything that contributes to the positive pressure is going to contribute to your mean, right? So if I have a patient that has a respiratory rate from 12 and we increase it to 14, what's going to happen to our mean? Okay. It's going to go up, right? Because now we're giving 2 more positive pressure breaths. So the total accumulation, okay, is on the positive side. The same thing, if I go from 12 to a rate of 10, I have 2 less positive pressure breaths. What's going to happen to my mean? Well, it's going to go down. So it's always on the inspiratory side. Okay, that's what we're looking at. So recruitment of the collapsed alveolar units. Okay, example, atelectasis. This is basically what our enemy is: secretions and atelectasis. The mean is used to reinflate the alveolar units and optimize the alveolar surface area for gas exchange. All right, so mean air pressure equals recruitment equals lung volume. Okay. So if the lungs, once they're recruited, okay, this is like that example. It's like that you want to go to the grocery store, all right, at 11 o'clock at night. You're in a small town. Well, unfortunately they're closed, so you can't get food. There's no fast food restaurant, so you're stuck. So you have to wait till 6 o'clock in the morning before they open up. So meanwhile, from 11 to 6, well, you don't eat. You can drink or whatever, and that's what you got to wait for. So when we have proper recruitment, all right, once the lungs are fully expanded, open, well, it's open for business. So now at 6 in the morning, hey, you go in, you go out, get whatever you need, and that's what oxygen does. Oxygen goes in, CO2 comes out. You have that traffic in between, but you have to have optimal lung volumes and optimal peak. Okay, so here's another diagram of the alveoli with the capillary circulation going through. So here's A, here's B, and here's C. So the optimal one, we want our lungs to look like B, and that's what you get from optimal P. All right, so let's continue with mean. Also, with mean, we also have improved oxygenation. Okay, because that's our goal. Okay, and that's the benefit, because like I said, again, once the lungs have recruited, open, expanded, all right, you're going to get the benefits of this. Association with peak, okay, another way to look at mean is think of this as super levels of peak, because people ask, what is mean? All right, some people are not that technical. We deal with residents, we deal with family members, visitors, patients, and they don't know what peak is. This is way above their pay grade, their knowledge depth, basis. So that's why we're here to explain to them. And an easy way to explain is that just think of this as super levels of peak. Okay, so mean air pressure less than 10 is a mild condition. Mean of 11 to 19, you can kind of look at it as a moderate condition, and mean of greater than 20, you can look at it as a severe condition. Okay. So let's take a look at this diagram here. This is a CT scan, okay, with a mean of 13 on conventional ventilation. So if you look at the lungs, okay, black is air, the gray and the white, okay, is collapsion, consolidated airways. So here we are. So this is our tidal volume goes up. So if you look, partial, the anterior, the anterior side of the lungs is expanded because you have gas exchange. The posterior side, well, it's collapsed. Now, if you look at the same mean error of 13, okay, on high frequency, well, look at the lung expansion. Look at all the black areas. The lungs recruited open. So on conventional ventilation, with your tidal volume rate and your PEEP setting, well, this is what you have. On high frequency, with a mean of 13 dialed in, well, this is what you have, because it's a lot more powerful way to deliver mean error pressure. All right, so let's talk about the principles here. Okay, so again, another way to describe high frequency is think about this as a super CPAP system. Okay, so there's flow going through it. Everyone remember, like when you guys first started school, we had the CPAP masks. Okay, you hook up to high flow, you have the mask and the different adapters. Okay, you breathe in, you breathe out. Well, guess what? This is the same thing. And here's where the patient connects. Here's where the air goes in, so it cycles through. So the higher the flow, the higher the CPAP valve we put on, the higher the level of CPAP we're delivering to the patient. That's what high frequency is. So, can this patient breathe spontaneously on the high frequency circuit? Yes.
Yeah.
Yes. So when the oscillator is not beating back and forth, well, there's air circulating through, so the patient can still breathe. And that's why sometimes when we listen to breath sounds, all we have to do is shut off the piston. So now you see the patient doing that, and you can hear the airflow going through. Because you're not losing that mean. Okay. Yes.
How can they breathe spontaneously if they're paralyzed?
Well, like I said, but our babies are not. Yeah, our babies we sedate, with fentanyl and Versed. In the adult population, we have to paralyze because it's such an abstract way of breathing. Okay, so that's what I'm saying. So I apologize for gearing this towards the neonatal side.
Okay.
But if your patient was awake, and the adult patient, and just on medium sedation, they can breathe. Okay. All right. So P, mean, equals oxygenation. So in that order. Okay. So we find optimal P. That's going to give us our optimal mean range. And once the lungs are recruited to the 100%, now we're going to have improved oxygenation. So let's look at this slide here. Okay, so in this slide, we have the different levels of expansion, different levels of PEEP, and here's our compliance studies. So at A, okay, our compliance is really low because our lungs are collapsed. We have atelectasis going on, so no air goes in. B, actually we'll see, our lungs are over-distended here, okay, because you have the plateauing effect. So we're too much. And here's B. Okay, you have this nice point down. Okay, so this is kind of B. So ideally, with this slide here, because I pasted two together, is that if you look at this inside triangle here, okay, this is optimal. So this is kind of in between B and C, is where we want our patient to be. Okay. So if you guys remember in the graphics here, is that you want to calculate compliance. Okay, we want our compliance to be 45 degrees. So this curve here is really a representative of what our lungs are. This is as the angle decreases more towards baseline, more towards zero. That means our compliance is getting worse. So when you guys look at your flow volume loops, you take a freeze. If it's more upright, good compliance. The flatter it gets, going towards 0 degrees, the worse the compliance is getting. Okay. All right, so hazards. Okay, so too much mean. Well, again, we got overdistension of the alveolar units. Okay. And once we have overdistension, what we're going to have? We're going to have a BQ mismatching, shunting happening, because the lungs are now compressing the capillary bed. So as blood tries to enter to the capillary beds to extract, actually it won't. It's like a blockage. So it goes and doesn't go anywhere else. Okay. So let's look at some possible injury hazards during mechanical ventilation. So in this diagram here, okay, there's three areas that we have to be concerned about. So the bottom, zone of de-recruitment of atelectasis. So we have to be careful with this because what's going to happen is that if we don't have enough mean air pressure, well, the lungs are collapsed. That's atelectasis. So sometimes we can call this atelectrauma. Okay. So right here, the low lung volume dilation, so the shearing effect. So the shearing effect means is that your airways, okay, it's going to collapse. So every time you breathe, the positive pressure is going to rip the airways open. And every time the airways rip open, okay, it releases toxins, and those toxins is what accelerates the ARDS process. So our lungs are meant to stay open and breathe this way. It was never meant to collapse, okay? So once it does, in order to open them back up, it's gonna rip. All right? So that's the shearing effect. On the top side, the zone of overdistension, again, because now our alveoli are overdistended, so now you lose that elasticity. Okay, so that's what happens to emphysema patients. Too much of this. So now, when you come back to the safe zone, that's how optimally we want the patient. How do we get here? Okay, this is the difficult part, because if you look on the high frequency ventilator, there's no graphics, there's no diagram, there's no waveform. It tells you, oh, look at that angle. There's nothing. All you hear is that's the piston running. So it's up to you to determine where that is. Okay, so it's overdistension. Okay, so again, edema, fluid accumulation can cause overdistension. Surfactant derivation, okay, can cause overdistension. High oxygen exposure, mechanical disruption. So this is something huge because it goes in hand. Okay, FiO2, O2 toxicity happens 24 to 48 hours on anything greater than 60% FiO2. So that's why one of the key things that we try to do is that we try to wean the FiO2 as fast as we can, all right, as safely as we can. Because what happens is that the high FiO2, okay, prevents the type 2 cells in our lungs from producing surfactant. So O2 toxicity, in turn causes the surfactant to not produce, and without surfactant, our lungs get stiff. So now you know why the ARDS process gets worse. When patients in ARDS, they've done a 90% for 2-3 days, and they're getting worse because, the body can't fix itself. And at the same time, the body is hurting itself, and because we have to give more FiO2. So that's why the surfactant degradation occurs as well. The recruitment atelectasis, repeated closure, re-expansion. We talked about stimulation of the inflammatory response, all those toxins being thrown into the airways. All right, again, inhibition of surfactant. Okay, local hypoxemia, and also compensatory overexpansion. All right. So again, if you look at this diagram, if you notice some of the slides are similar because, like I said, I really want you guys to really focus on the main point is that we have to get the right amount of mean, the right amount of peak, optimal mean, optimal peak. Okay, so the more you visualize it, the more you remember. So again, A, B, C. Which one do we want? We want our alveoli to look like B, a cluster of grapes. So again, here. On this flow volume loop is more representative of A, okay, area of de-recruitment. Over here, on this flow volume loop is indicative of C, area of overdistension. Okay, because look how bowing it is. Look at this B plateauing. Okay, so in order to get B, what we want to see is that we want to see the graph go right there and come down, right? Go to the point. And once you hit the peak, drop down back to baseline. That's your optimal. Okay. All right. So if you look at this slide here, okay. So we have on this bottom compliance under distension, normal, and over distension. On top, we have this slide here, a flow volume loop. Okay. We have increase, optimal, and decrease. Inspiratory, expiratory. So if I look at here my actual flow volume loop. Okay, this is what we're looking for. So in this middle zone here, on the outer zone, we have too much, and this little dotted line here shows you that we have over distension. Okay, so when the curve fits into these guidelines, these shadows, then you know that you've overdistended. Okay, so we just talked about mean. Okay, mean is also, if you look on conventional mechanical ventilation CMV, that is also P. Okay, because we all understand what mechanical ventilation is. You guys know what tidal volume, mean, rate is. Okay, but when we talk about high frequency, when you say mean, it's like a foreign language. Okay, so what mean is, again, just think of it as P. That's all we're doing. Okay, so let's talk about hertz. So the definition is a standard unit of measurement used for the measurement of frequency. So all the physics, remember the physics class? Okay, physics 1, intro, okay, the oscilloscope. Well, that's what we're measuring, frequency. Frequency, measurement cycles per second. Okay, and this is what controls our ventilation. It helps to eliminate or retain CO2. So how we do that is the faster our frequency, higher the higher the hertz, the faster our frequency, the more breaths we're giving out. Okay, and you want to retain CO2, well, drop the hertz. So hertz is 1 hertz equals 60 breaths per minute. Okay, so that's the factor. So if you guys want to play around, if the baby's on 10 of hertz, times that by 60, okay, guess what? The baby's getting 600 breaths per minute. You increase your hertz to 15 times 60, that's going to give you 900 breaths per minute. Okay, that's what they're receiving. So this association is with the rate. All right. Also, it's also associated with inspiratory time. Okay? Because on conventional ventilation, we set our I times, right? Okay. And some of the advanced modes we don't have to. But if you look at this, okay, 600 and 900. If I have to give a breath 600 times a minute, okay, and then I increase my hertz to 15, I'm giving a breath 900 times a minute. What's going to happen to my inspiratory time? There you go. It's going to reduce. So it's going to be minimal. So which means that the baby's going to be exposed to less positive pressure on the inspiratory side of the breath. But guess what? What's going to happen to the mean? Because you've increased your rate from 600 to 900. So the overall exposure is still the same. Okay? So it's going to be even higher because now you have 300 more positive pressure breaths the baby's receiving. Okay? So what we do here is that that we kind of focus on hertz as a way of kind of gauging is like our neonatal population where we do inspiratory times of 0.3 to 0.35 seconds. But when the babies go to peds, okay, to 1-year-old baby, 2-year-old baby, we automatically jump the inspiratory time to 0.5, 0.6, even 0.75 seconds. When you become adolescent adulthood, the inspiratory time goes to 1 second. So if you think of this as when you set your hertz from 3 to 15, also look at your inspiratory time. How many breaths per minute do we want to give this baby, this kid, this adult? Okay, and that's what you can, and with that, with experience, you get more comfortable. But also understand that the lower the hertz, the higher the inspiratory time, and what is that more reflected towards? Our pediatric adults. The higher the hertz, 10, 11, 12, 13, 14, 15, that's more indicative to our neonatal population because they breathe faster. All right, so this is just a different diagrams of hertz. So we have 110 hertz. Okay, you got the faster 220, a little faster 440. All right, 880. Okay, so if you want to say this is hertz of 15, this is hertz of 13, this is hertz of 10. Okay, and this is hertz of 6. Okay, you can put any number you like, but the key is that if you see the amount of frequency. Okay, here's one cycle, up, down, up. Okay, that's one cycle, up, down, up. Okay, you have your peak and your trough. Peak and trough, that's one complete cycle. In 1 minute, look how many cycles, and how many cycles. Okay? So, think about again, you want to give the baby more breaths. So as you give the baby more breaths from here to here, what's going to happen to our CO2? It's going to decrease because we're going to pull it off because we're giving more breaths per minute. So think of that. Okay. If I go from here to here, what's going to happen to my CO2? Yeah, this is going because I have less breaths per minute, so I'm going to retain. Okay. So down here is our frequency control on the oscillator. Okay, so you can dial it up, dial it down. Okay. So here's our piston. Okay, so this is like the main mechanism, okay, for ventilation. So as the piston goes back and forth, back and forth, back and forth, okay, so that's what pushes air in and pulls air out. So the magnet controls the piston function, okay, helps control hertz, helps control our amplitude. So here's another diagram cut out of the magnet, and on the B it's even bigger. Okay, so frequency controls the time allowed, distance from the piston to move. Okay, so therefore we can increase the hertz or decrease hertz as needed. So if you look at here, 8 hertz and 6 hertz. So on one cycle, look at the difference here of the surface area. You have this and you have this. Okay. So that's all this meaning is. As we go up or down, the various surface area is going to increase or decrease. So you can kind of say, well, this is kind of increased my tidal volumes, right? Because I have more surface area, okay, compared to this. So hertz adjustment, same thing. Stroke volume will increase or decrease if the frequency increases. You have a short cycle time, smaller inspiratory time, or equivalent to a smaller tidal volume. Same thing, if frequency decreases, you have a longer cycle time, which creates a longer inspiratory time, and then you may get a larger tidal volume as the end result. Okay. So again, here's our stroke volume. So if I decrease my hertz, I make it smaller. Well, look at my surface area. My volume size decreased. If I increase my hertz, if I decrease my hertz, what's going to happen to my volume, my stroke? It's going to increase. So that's why the surface area is more. Okay. All right. So strategies. So babies less than 1,000 grams. Okay. This again, this slide was like I said, 2 years old. But typically 15 is what we start at. But times are changing. Okay. Now we even start at 13 instead because 15 may be too low. So everything changes. So that's the saying. What we learned today, what we learned 10 years ago, 15 years ago, everything's going to change. Okay. So we have to understand that. So now on a 1,000 gram or less, so you can go at 13 or 14 hertz. So, and same thing with this here, 1,000, 2,000 grams. So 12 to 11 is fine. Okay. 2 kilos to 10 kilos, we start at 10. And same thing, 13 to 20 kilos, we can go to 8. Okay, so our pediatric sizes. So in peds, we never want to go below 10. Okay. So in adults, I didn't put adults here down, but adults, we start from 3 to 5. Okay, so 5 is where we start, and we go down to 4, go down to 3. So we just talked about hertz as a review. So we said that hertz is equivalent to rate on conventional mechanical ventilation. So again, math related to P, hertz is our rate. So let's talk about amplitude and power, what this is. So amplitude. This is called our delta P. Okay, remember our delta P is a PIP minus P. Okay, on mechanical ventilation, that's a delta P, the difference. Stroke volume, the distance that the piston moves, resulting in a volume displacement. Okay. Displacement creates peaks and troughs. And this is what we look at as our chest wiggle or vibrations. Okay. How much is that chest moving in and out? Okay. Because because you may be able to visualize it, or you may have to put your hands on the baby's chest and feel it. Okay. So this is our primary control to help eliminate CO2 and also retain CO2. So we just talked about hertz, right? We said hertz. If we increase or decrease, we can eliminate or retain. Well, guess what? Just like our amplitude, we can adjust our amplitude, increase or decrease to eliminate or retain CO2. So which one do we use first? Okay, is that amplitude is our primary control for CO2. Hertz is our rate. Okay, so just like when we set our patients on mechanical ventilation, we set the tidal volume, we set the rate, and we set our PEEP and our FiO2. Okay. So now, if the CO2 is high, all right, and we have our tidal volume at the optimal setting at 6 cc's per kilo, okay, and patient has a high CO2, what are we going to adjust? The rate, because we don't want to mess with the volume anymore. And that same thing here with the high frequency is that once you set your hertz, you leave it in there, and don't mess with it. So anything CO2 related, we want to control with our amplitude. All right. And our range is anywhere between 8 to 130. Okay, so like an adult populations, like we had an adult patient last week that, for example, that we set our amplitude 120. Okay. So here's our amplitude control. Okay, this is our power. So then let me switch over here. Okay, so let's talk about what power is a little bit here. Okay, because a lot of people, some people understand it, some people don't. This is how we control our amplitude. Okay, that we just turn the dial and we visualize on the patient how much their chest vibrates. Okay, how do we know what the optimal setting is? For babies, we want to make sure that the nipple to the umbilicus is shaky. Okay, because at the umbilicus, that's part of the lower lobes. So to ensure that the lower lobes is participating in the ventilation process, we need to see the umbilicus shake. On a neonate, if you see the thigh shake, well, that's too much. Okay, so that's what we need to back off. So that's kind of our range. All right. So on conventional ventilation, when we set our tidal volumes too high, what kind of curve are you going to see? You're going to see that peak on the flow volume loop. So that's how we can back off. Okay. And also we can also calculate, based on their tidal volume, how many cc's per kilo we want to give them in the optimal range. So that's what we do. Now, here's an example. So patients on an amplitude of 69, and their power, this number in the dial says 6.0. Okay. So 2 hours later, you come back to do another vent check, and you notice that their amplitude says 65. No one changed it because you look at the power, it says 6.0. So you're like, well, what's going on? Okay. So the first thing that comes to your mind is that, hey, did someone touch my ventilator? Okay. So you look at your power setting. Well, it says 6.0, like you documented. So no one touched it. So now you have to think, well, why did my amplitude go down? Okay. So lung compliance is key. You have to have compliance in your lungs. All right. So now, what happened is that at the power of 6, my amplitude reading due to my compliance is 65, so I went down. The lungs got stiffer. What do I have to do on my dial? I'm going to have to increase it, right? So as I increase this, my 6 would go up. It may go up to 7. So say that I turn my dial, okay, to get back to 69, I do whatever it takes. Once I hit 69 on my amplitude, I look at my power to see where my number is. It says 7.0. So I went up by 1 point. Okay, tell me how stiff is that lungs? Yeah, it's very stiff because you went up a whole point. If you look at the dials here, you have 0, 2, 4, 6, 8. So each notch is an increment of 2. Okay, so you had to go up by 1 whole point to get back to your original amplitude setting of 69 to get the proper chest wiggle. Compliance is getting bad. Now on the reverse, you do that 6, and you come back, and the amplitude says 75. You're like, whoa, what happened here? My amplitude shot up. What happened? So you look at your power, it says 6.0. So now you're thinking like, okay, well, my amplitude went up, so which means that my compliance must be getting better because there's less resistance. So what do? So you turn the dial down to get it back to 69. And then when you do that and you see 5.0, there's a 5 in that window there. So now your compliance improves so much that you go down by 1 whole point. Okay? That's how we use power. All right? We don't, like I said, so sometimes this number is taken for granted because it's not something that we record on a daily basis. But if you have a sick patient, you want to progress where they're at. Okay? That's how you can tell, what the power number is. Okay? So again, there's our piston controls. Alright? So amplitude equals our chest wall expansion, and this is what our chest wiggle is because it's going back and forth. Okay? And this is equivalent to our tidal volume. Let's talk about the adjustment here. So when we talk about stroke volume, increase decrease. If I increase my amplitude, go higher, okay, I have a higher delta P. So my tidal volume is going to be larger, but look at my surface area. It's a lot larger. Same thing if I decrease my amplitude. So if I took my PIP minus my peak, that's going to be my delta P. Well, I'm lowering my delta P, so I'm going to get a smaller tidal volume. Okay. Do we see these numbers? We don't, because like I said, this is not a ventilator. Okay, so it's not conventional. What it tells us our tidal volume. So in theory, that's what's happening, and that's what we have to understand. Okay. You guys will get this whole presentation afterwards. Okay, so again, so this is just a little equation here. Alveolar ventilation during CMV is defined as our frequency times tidal volume. Okay, so that means what? That's minute ventilation, right? Okay, alveolar ventilation during high frequency is defined as frequency times tidal volume squared. Okay, so do we know what our tidal volume is? No, we don't. But the mathematicians and engineers, that's what they calculated. Because we use those microscopic tidal volumes at a faster rate. Okay, so that's how we're able to get our alveolar ventilation. What's more important, alveolar ventilation or minute ventilation? Okay, how many say minute ventilation is important?
As opposed to alveolar ventilation? Jeez.
How many say minute ventilation? How many say alveolar ventilation is important? Okay, 3, 4. So alveolar ventilation is the most important thing you want to focus on, because alveolar ventilation means where's the ventilation occurring? In the alveolar area. Okay, where does gas exchange occur? In the alveolar area. Minute ventilation can incorporate dead space, the upper area. Okay, it can be just dead space ventilation, and that can be part of the minute ventilation process. But I guarantee you that if you're able to improve your alveolar ventilation, that you will blow off that CO2. And we have a very neat device in our department, okay, that measures alveolar ventilation. Okay, and that's the NICO device. Okay, that's volumetric CO2. What volumetric CO2 is, that you see those professional athletes, doing the stress test with a mask. They breathe in and they exhale. Okay, so when they exhale, okay, the scientists are measuring their exhale CO2 from their alveolar lungs. So that's what they're trying to maximize their consumption and what they're producing. Same thing with us here is that machine, okay, it has a mass spectrometer. So as the patient exhales directly into it, it samples that sample. It tells us exactly what our alveolar CO2 is going to be. So if that number goes up, okay, that means that the patient's breathing more CO2 out. So as we make changes, we can see if the number goes down, that means that the patient's not exhaling his alveolar CO2, because there's really no defined number on that system. Because people want to see 35 to 45. Well, there's no such thing as that. So we use it as a trending device. If it goes up, that means, hey, more CO2 is coming out. If it goes down, less CO2 is coming out. Okay?
Dave, can we put has anybody ever put the NICO in line with the oscillator?
No, because the reason why is because the small breaths, okay, and the oscillations is not enough to sample. And plus you have the bias flow going through the system all the time, so washing out the CO2. So
Okay.
that's why it makes it so difficult.
All right.
But maybe with new technology.
Hopefully, yeah, 5-10 years from now.
Depends on
Either that or do it at night.
So anyway, so amplitude, let's review. So we talked about amplitude. So when we talk about on conventional ventilation, well, we're saying that this is our tidal volume. Okay? So MAP, mean. Hertz is our rate. Amplitude is our tidal volume. So, like I said, so now when we talk, we're on the same page. When I say amplitude, I'm saying tidal volume. How much is the chest moving out? Okay, the more the chest expands, the higher tidal volume. Just like when we bag a patient, all right? Do you want to know how much peak pressure to give the patient? Well, see how much it takes to move the chest wall. So as you bag, you look at the pressure manometer reading. If it says 20 to move the chest wall just enough, well, guess what? That's what you set your ventilator on. All right? If the baby's lungs are stiff and you have to go 25 just to get to see the chest wall moving, well, guess what? That's what you need. Now here's the kicker. What happens if the patient's chest wall is so stiff, or they have some sort of genetic disorder where they have stiff lung disease, and you're bagging them, but the only thing you see is their abdomen distend. So when you bag, you see their abdomen distend. Okay? Are we still ventilating them?
Yes.
Yeah, we are. Because their compliance, their lung disease is so stiff that this is the least resistance. So you're going to see your belly move. Okay? Now, people are going to say, well, you're not bagging hard enough. Well, no, you are. Because anything higher than that, well, you may cause damage. All right? If your O2 saturation is stable and your belly's moving, okay, patient looks pink, red, well, guess what? You have enough. So understand what the lung dynamics does. You don't have to see this part move. If you see this part move, okay, that tips you off because, hey, this is too stiff. They may have a restricted disease, okay, pulmonary fibrosis, all right, just like our kids, the CF is coming through, or they may be a genetic disorder. All right, so percent inspiratory time. So controls the time for movement of the piston during the inspiratory phase, adjustable for between 30 to 50%. So this is what we always do, 33%, because that's going to give us our 1 to 2 IU ratio. Okay. 50%, we can go to 50%, okay, on the premise that we need oxygenation help. The oscillator is very versatile because this is what we typically do it, okay? Because we use a mean to control our oxygenation. So we say, well, 33%, we want to make sure that the patient's ventilating. But if your patient is not oxygenating, we have the option to go 50% on our inspiratory time. Because our PO2, recruitment, we want more. So think of this as a 1-to-1 ratio, like we do on conventional ventilation, you know? We inverse it, because we're trying to get the 1-to-1, trap the air. Okay? And that's what we're doing here with the same thing. Okay? So, 33% is for our ventilation process. If we have to go to 50%, it's because we need it for the oxygenation help.
Would you go to 40 first, and then if that doesn't work, go to 50, or do you go right to 50?
Yeah, you can, because you have that sliding rule. So you can go above that. But if you really need to use it, just hit 50, because it's very obvious. You know, because the next step is behind you, and if you don't give report thoroughly, what they're not understanding. They see it 40, like, oh, what, you cuckoo or what? You know, so they turn it back to 33, not thinking that this going on. So by just going up to 50%, and then you know ideally that, oh, it's 50%, so there's something here that we need to investigate. And something could have been missed from report or vice versa.
Do we discuss it with the doctor first and then
Oh,
get
yes.
an order for it?
Yes. This one you have to, because I said this is standard conventional settings. This is, if you're gonna do this, you do need an order for that. Okay, because this is away from the norm.
And most likely we'll see the results within just the next few minutes.
Yeah, correct. Because like I said, because I mean the process, because you have so many breaths, and also on our pediatric and neonatal babies, the lungs are small, where the recruitment happens faster. On the adult side, you have to give it a good 45 minutes to an hour. Okay.
Is there a pathology where that may not be an ideal move? Like, let's say the patient's already overdistended, or there's a chest tube, you would not then try that?
Yeah, I mean, like I said,
This is more like if the white out, you're not recruiting?
correct.
It's like the worst case scenario. I've
Yeah.
only seen it once in peds.
Yeah.
One time, PICU. Dr. Ray was like, go up to 50%, and this patient was on the way up to heaven. I mean, we were on maximum settings,
Yeah.
and it changed. It's like 4-to-1 almost.
Yeah.
Air trapping, it's really good. Patient.
That's it. I mean, if you have to use this mode, I mean,
Really like last
survival
case
survival is very slim to none.
Very slim to none
Yeah.
patient type. But we ended up going 50% on that.
Yeah.
It was one time scary. I was
Yeah.
scared.
No, because like,
Had a
remember,
pneumotor,
Yeah.
but bilateral chest tubes already,
Yeah.
so we were already.
yeah, it was a side case for that patient if you have to do this.
Because the problem I see sometimes is that we're not oxygenating,
Yeah.
but we're not oxygenating because the patient is so hyperinflated.
Correct.
And so that would be that's the contraindication.
Correct. And that's what I'm saying. That's why you have to get the big picture, and also by looking at the chest X-rays and vice versa, what's happening. Okay. All right. So here's our inspiratory percent time control. Okay. So just turn this dial however way you want. 33 is the industry standard. If you have to go to 50, it's acceptable, but make sure that you have a justified reason why. Okay, so let's talk about inspiratory time. So we talked about so recommended 33% because it prevents air trapping. It helps to assist with CO2 elimination and assist with ventilation. So this is our IE ratio of 1 to 2 ratio. So 33% on the inspiratory phase, and the remaining 66% is on the expiratory phase.
Isn't that 99?
Which one?
33 and 66 is 99?
All right,
Whatever that 1%.
all right. 33.3%
Okay.
and 66.67%.
It's all done with mirrors.
All right, so when we go to 50%, okay, so it allows for air trapping because we're creating auto peak. We're not allowing the patient to exhale no more. This is with oxygenation. I think it was a 1-to-1 ratio, so 50% on inspiratory phase and 50% on expiratory phase. Yeah, even.
It's a lot of phase.
All right. let's talk about our bias flow. Bias flow is a continuous flow of gas circulating throughout the circuit. Okay. Normal range, 15 to 20 on the A and 20 to 30 on the B. Higher the flow rates help to eliminate CO2 from the circuit. Higher flow rates may help increase mean air pressure, because what's happening is that you create higher back pressure. Okay, so resistance. So remember what we learned in school is that when a patient exhales, we don't want the bias flow through the circuit to be too high, because when the patient exhales, if there's too much circuit, too much flow, then they can't blow out against that resistance. So that's to say we have to watch out how much bias flow we put there. So and that's what's happening here, is that when we increase our bias flow to say 35, or 40 even, well, our mean's going to increase because there's more pressure in the circuit. So that's how you can get a higher mean that way. Okay.
Is there an ideal way to set your bias flow?
Yes, and
Because that's the least discussed parameter, and it really makes a big difference.
yes, there is, and I tell you right now, I forgot how. Okay, but traditionally what we do is that you have your micro preemies. They don't need 20 liters per minute. 12 to 15 is what they need. That's how you start. You always start low and you work your way up. And then your adults, okay? Adults start at 30 automatically because they're big and you need the more mean and then the amplitude, so you have to have that higher bias flow. Pediatrics is a tough area because you have that broad range. You have that 1-year-old, a 6-month-old, that's more like a neonate, to the adolescent, 16, 17-year-old kid. That's going to require 30 liters. So that's what I'm saying. The pediatric areas, PICU, you guys have a tougher job because you guys have to gauge and how it goes. But with the peds, if you start at 20, you're good to go. NICU, 12 to 15 is an ideal way for the smaller babies. Okay, term babies, match it up to 20. Peds, just go from 20 to 30, and just keep it that way. So you're small, a 6-year-old kid, go to 25. All right. After that, your teens, 11 to 17, 18, 25 to 30. Okay.
What I'll do is I'll drop the flow a little bit,
Yeah.
like 1 or 2 liters, and then I'll go up on my mean,
Mm-hmm.
and then I keep doing that until there's no more mean left.
Right.
So then I thought, okay, I'm too far.
Correct.
So I'll go back up 1 or 2 liters, and then I'll leave it like that.
Yeah. So what Ron was saying is that's how you can calculate how much bias flow that the patient really needs. Okay, so you set your bias flow low and your mean, and then you work your way up that way.
Because you really want just enough
Yeah.
to do the job, just
Yeah.
to perform the work.
And that's what I'm saying. So that was, like I said, that one there, like I said, if you don't do it on a regular basis, you really forget. That's why there's a way. That's what I'm saying. And I'm glad you brought that up. So, but to make it user friendly.
I'll show you later.
To make it user friendly, that's what I'm saying. So, if you just start with the lower and work your way up. So if you need more mean, well, you can always add more flow. All right. So primary controls. We have our amplitude, our hertz, our inspiratory time, and our bias flow. Okay. This is what helps control our CO2. Okay, so ventilation strategy is here. If CO2 retention persists, decreasing the cuff pressure to allow gas to escape around the ET tube will remove the fresh gas supply from the Y connected to the tip of the ET tube. Okay, so what does this mean? Is that all the adults and some of the pediatrics has this cuff. Okay, so on the neonatal side, we use uncuffed ET tube. So we're automatically having this process occur. Gas goes in, the pressure builds up. Okay, so as pressure builds up, the CO2 is able to eliminate out. In the adult area, so it's just like this patient we had last week, is that we were having CO2s in the 60s and 70s. The ET tube was cuffed. Well, it's like I'm glad that Gloria thought about this, that she decreased the cuff a little bit, and when she did that, she allowed the releasing of the CO2 built up in the lungs. Because you got to remember with high frequency that you don't have this tidal volume that pushes air in and pulls air out. You have these microscopic, dead space breath, going back and forth, coming back and forth. So you have this diffusion type of gas exchange. And that's what happens to CO2 is diffusing out.
I don't do that often with adults. I just have a question.
Yeah.
Generally speaking, you deflate the cuff or partially deflate the cuff automatically?
Yeah.
Because you don't do the venous. Go ahead.
No.
You know what I mean?
Yeah. So you do do that based upon your blood gas results clinically. So what happened was that this patient was on an amplitude of 120, and his CO2 was still in the 60s and 70s. We increased, so there was no more movement for the amplitude. All right, our mean was in the right area because our saturation was like 92.93 on 100%. So the next move is that we've exhausted our amplitude. Okay, so now you go and decrease your cuff pressure just a little bit. Don't hold it deflated because you're going to lose your mean. Okay, because that's it. Because your mean is your peak. So once there's a leak, well, it's going to dissipate out. So that's what I say. You just partially decrease it.
When you initially put an adult on a oscillator, do you initially deflate the cuff a little bit?
No, just leave it.
See, that's what I was taught. I didn't know
But
that.
in PICU, yes.
Yeah, so it's in PICU. If that's what they want, okay, then that's fine. But
Usually deflate the cuff, that's all.
yeah, because initially you don't need to. So you do that based upon clinically. If you have a CO2 retention, you want to deflate the cuff a little bit.
See, I always thought that when the flow goes down the ET tube, because of the way the dynamics of the flow, it's not going to come back out the tubing, meaning out the ET tube.
Yeah.
You have to have that route of escape.
Yeah.
But what you're saying is, the dynamics of the flow is that if you can get flow in through the ET tube and flow out of the ET tube.
No. Flow out of the ET tube you can, and that's what I'm saying. Remember the mean air pressure because we're creating peak.
Yeah.
Mean. So if your leak is too big, okay, it's gonna dissipate out. The neonates, okay. One thing nice about them is that their lung space is so small that we don't have that problem. But as you get to the bigger kids and the bigger adult population, their lungs are huge. So in order to track that mean, you can't completely deflate your cuff because you're going to lose all your pressures. And then when you're cranking up high on your mean in the 30s and 40s, well, you're going to have a hard time because the ventilator is kind of like a BiPAP machine. If you have too big of a leak, well, your pressures are going to have to work harder. You're not going to get the same result.
So initially, do not deflate the cuff.
Yes. Like I
Okay,
said,
see, I
to
never
me,
would.
it's a lot easier to just keep the cuff inflated and
Okay.
then get your settings. Once you got your settings, then get your gas and
Yeah.
see where you're at. And if you have any CO2 retention problems, well, then now take those strategies and start decreasing the cuff and get a repeat gas because it's a guessing game. This is all a guessing game of what we're trying to do. But these are educated guesses that we're making.
I'll call Gloria.
Okay? All right.
No, I'll call you.
I'll call Gloria.
We're gonna call you, and be like, Ed, I'm over here right now.
All right. So controls for oxygenation. Okay, so mean air pressure. Our bias flow. Okay, so we can adjust our mean. We also have our bias flow. I can increase my bias flow, create more resistance in the circuit, so it's going to create a higher mean for me. Or I can decrease my bias flow, which will create less resistance and also will have a lower mean for me as well. FiO2 and inspiratory time. Okay. So there's a baby. Okay, here's a baby kangarooing, mommy holding.
Oh wow, you guys will do that?
Yeah. Just remember, this is just a ventilation process. This is not, oh my God, hands off. I can't touch my kid. No.
Wow.
That's
Well,
okay.
the one thing, because of that, the circuits are so stiff that you're gonna wanna cuddle and
But
excavate the I don't know, there's certain points.
the
where I'm
invention of the flexible
Don't show
circuit.
Elena that.
The invention of the flexible
Don't show
circuit
Elena that.
gave us a lot of flexibility.
We're not.
Because remember, baby friendly means that, okay, that the bonding, because remember, in mom in utero, the baby's bonding with mom all the time. Because, they're premature now, it's like hands off. What the baby needs that touch. This is how they develop. And the more we do this, the better they feel, the better they respond.
That's too much customer service.
Well, that has to worry about the patient getting it.
You've seen that?
No,
You have seen that?
Don't show Elena that,
we do
because
that.
we're already into the whole baby bonding
Like
time,
I
which
said,
is fine.
we've
But
done
I've
not
never
an oscillator, like,
I
I'm
think it's
gonna
smarter to
be
get
like,
a bed and lay the mom down and put the baby on top.
what can I put him on a big board and you can cuddle the baby, but can the baby be like this, like don't move?
When I was going to too.
I mean-
When I was at Olinda,
Baby better be taped to the board. I'm not,
If the
you
baby
do
stable
this
enough,
and it's like,
mom wants to hold. Okay,
Wow.
let's go. Let's get it on.
don't show Elena.
And then all the water in the system.
Yeah, it's on.
So like I said, so understand that. okay, that this is possible because,
We'll do it, whatever.
okay, because I didn't have her pose for me, okay? So this is possible out there, so don't be afraid. Okay,
We are not.
Okay, afraid means is that you don't know. That's what I'm saying. That's why I'm sharing this with you guys so to show you that what the capabilities are. Okay, if you don't know your capabilities, then that's where the stopping happens. Oh, I can't do this. No, it's not the case. Okay, and here's adult with a big flexible circuit.
Okay, so this is time to ask the question. So the circuit used to be stiff, now it's pliable,
Yep.
and you can make almost like a 45-degree
Right.
angle turn, and that's okay?
That's okay.
There's no dampening
Yeah,
or
yeah.
anything like that?
Yeah, because back then, when the engineers first started, they thought everything had to be straight shot, but then later on they found out, with their studies, that's what they came out with, the pliable circuit. That it's okay to do
It's okay.
because the energy loss is not as big as people thought it was. Everyone thought it had to be a straight shot,
Yeah.
and that's what I'm saying. That's why as time goes by and they learn more, they're finding out that there really is no difference.
Wow.
Where does the weight start to change?
Yeah,
Done.
the 35 kilos.
35.
Yeah,
Everything's 35.
Yeah, that's it. The A's build up to 35, and above 35 is the B.
Yeah, you could never go on a date, man.
Could I go on the A?
Yeah,
No,
you can go
no,
on
no.
the
All right, so let's talk about the benefits. Okay, so enables ventilation goes up the closing volume of the lower alveolar pressure swings. Safe way of using super levels of PEEP. Optimal lung volumes with adequate ventilation. So we have our delta P. And also we create less volume trauma. So reduction of the volume swings, because remember, there's no tidal volumes, opening and closing. Reduction in airway stretching, again, the lungs don't overstretch anymore. Minimizing overdistension, and minimizing exposure to high PIP pressure. Okay, so this is all the goal. So once the lungs are expanded, then everything else, the piston goes back and forth. Okay, so let's take a look at this tracing here. So here's our tidal volume, that big swing. Inspiratory phase, expiratory phase, inspiratory phase, expiratory phase. Well, now here's our high frequency. If you look, is that you don't have these big swings no more. So you have your peak and trough, peak and trough, peak and trough. Okay, it's very minimal. Here's our mean of 30. Okay, and then we're swinging, about 5 above and 5 below in our amplitude. Compared to conventional, we're at 10 to 40. Okay, what's our delta P? 30. That's huge. Okay, overdistension occurs anything above 30. So 30 to 35 is where overdistension lung damage occurs. And what we're doing is we're keeping the lungs open at 30, mean at 30, because that's how sick these lungs are. Okay, that's how stiff they are. And we're going 5 above, 5 below. So we're still within the normal range. So preventing overdistension occurring.
Let me ask you a question. Okay, so you have a mean here of 30.
Yep.
Let's just say, and I know the chest wiggles depending on compliance, but let's say you have the amplitude at, like you said earlier, 120. Is it possible for the swing to come down below 0? And is that something you do not want to do? Or is that really doesn't happen? You know what I'm saying?
Yeah, no. Yeah,
Because a lot of people would think when you go below 0, are you closing?
Yeah, no. I mean, so that part there, you're not closing the lungs off because the mean is always there. The mean is what keeps the lungs open, okay? And then the amplitude comes in behind, so the amplitude comes behind and just shakes the lungs back and forth, but it will never completely close to less than 0. To answer your question that way.
Yeah.
So think of it this way, is that if your baseline is 30, okay, I'm going above and below. Okay, I know your pressures are 0 and you have that big swing, but your baseline is not 0. It's actually moved up to 30, and then that's where you're swinging back and forth. So as long as your mean's not at 0, because 0 means that the lungs are collapsed. All right, so that's how you can kind of gauge it that way. Okay. So if you look at this diagram here, so like I said before, like we said, is that the goal of high frequency is to get the lungs inflated to the optimal point. Once they're inflated, now we come in with the amplitude and we're shaking the patient. Okay, and that amplitude is our tidal volume. So the mean, again, all right, is think of that as our tidal volume on conventional ventilation, our peak level. We found the right area. Now we increase our amplitude, goes in, goes out. If our CO2 is too high, well, we increase our amplitude. But as long as the lungs are stayed open, that's the main point. If the lungs are partially collapsed, what happens to the lower lobes? Okay, so if this is my lower lobes and this is my upper lobes. Okay, my lower lobe is not participating in the ventilation process because it's not curved open, it's closed. So by adding more mean, now we open up this. So now the whole entire lung is re-expanded. So now it's participating in the ventilation process, and that's what we're looking for. So that's what I'm saying. Optimal mean is so tough and it's hard to find, but at the same time, you have to achieve it in order to ventilate properly and oxygenate properly. Yes.
Yeah, in the clinical, how you assess the optimal?
Yeah, and so we'll talk about that as well. Okay. So everyone, well, before I go on, everyone understands that high frequency can be used for ventilation failure as well, right? And as well as oxygenation failure. So we always associate with oxygenation failure, but we never talk about ventilation failure. But we can use high frequency for ventilation failure as well. Because remember, if the lungs are collapsed, okay, nothing goes in, nothing comes out. And so that's why you have the ventilation failure. Even though they're oxygenating correctly, because remember, they have other parts of the lungs that are very efficient. So they can still have a PO2 of 80, but their lower lobes are collapsed, but then your CO2 is at 100. Does that make sense? Yeah, because this part of the lungs is oxygenating because the AC membrane is fine, but your lower lobe is totally collapsed. That's why you have CO2 retention because remember your dependent zones of blood flow. All right. So the body has zone 1, zone 2, and zone 3. Well, zone 3 is 75%, 80% of our blood flow goes through the zone because it's gravity dependent. So when I'm upright, where's my dependent zone? My lower lobe. When I lay flat, where's my dependent zone? My posterior lungs. When I lay on my stomach, where's my dependent zones? My entire anterior side. So our patients are not standing upright. They're at 45 semi-forward. Okay, so where's the dependent zones? In the lower lobes. And if it's collapsed, allostatic, what's going to happen to your oxygenation? What's going to happen to your CO2 ventilation? CO2 can't get out. All right, oxygenation can't get in. So that's the reason why, by finding optimal mean, getting those lower lobes re-expanded, so now they can work. Okay, now we're in business. If you can't get that, then you're going to be chasing your tail constantly. Okay. Okay, so again, this diagram here. Okay, so let's take a look at this diagram. You know, the way it was composed. So what I did was that I took each segment of the flow volume loop curve to show you what it's going to look like. So it's shaking here, it's shaking here, it's shaking here, and it's shaking here. Okay, so this is all the vibrations are occurring in the curve. Now our goal is to find optimal mean. Well, it's overdistended here. So by cutting back, dropping the mean a little bit, well, guess what? Now I've expanded my lungs correctly, and I'm still shaking everywhere. So it's a dual process. Your mean is one control, and your amplitude is a separate control. That's what's nice about it. You have two independent controls that you're controlling. All right. So we have the high frequency Care Fusion products. Okay. So here we go. So we just talked about the theory. So let's talk about the mechanism of how everything applies when we do high frequency. So you have 6 processes that's occurring. Okay, that's helping you with the oxygenation and ventilation process. So number 1, you have the direct bulk flow. Here's the bulk flow of gases coming in. Number 2, you have the longitudinal dispersion. Okay, so up here, the gases are dispersing. Number 3, you have the Pendeloff. Okay, so you have collateral circulation. You have asymmetric velocity profiles. Number 4, so you have vectors, the velocity, air comes in, and then on the, remember the pressure goes from high to low, like an airplane? So you have the airplane flap here, okay? As air goes over it, what happens to the pressure? It's lower because the rush of air drops the pressure. And all the pressure below the wing is high, so pressure goes from what? High to low? So pressure goes from high to low, so the plane lifts. Well, the same thing here is that as our forces come this way, okay, the side pressure is high. So this is allowing air, CO2, to escape out as oxygen comes in. We have the cardiogenic mixing, okay, so over here, so we have the car. So the CO2 is diffusing across. And also last one, the molecular diffusion, number 6. Again, so everything's diffusing across. CO2 diffuses across to the lungs, and also oxygen diffuses in. So these are the 6 different principles that applies to high frequency.
Of those 6, which one are added to oscillations and which one do you see mainly with conventional? Like, you get pendulum with conventional, right?
Yeah.
But let's say, so which ones did we add?
Well, so we add so this part here is the number 4 of the asymmetric velocity profiles because of the bias flow and also with a piston going forward and going backwards. Okay, so that's what's nice about this one here, because like I said, that piston, depending on what your amplitude is kind of really what dictates how much. And all the gas diffusion, the mixing, that's just a byproduct of the mean in the lumps. Okay, and you also so with number 3 for the pendulum, like, these are your pros or cons, so then you have collateral circulation here as well. So if the lungs are blocked open, it'll come on the reverse side and open it up that way, and kind of like the reverse opening and everything. So I mean, to answer your question about which is added more from a high frequency, I would say probably number 4 is, and at the same time probably number 2, because of the dispersion effect and also the asymmetric velocities, because of the bias flow and also the amplitude going back and forth. The remaining part, it's like this is all you can think of this as more mean associated. The diffusion is all more mean because of the high-low pressure that you're creating in the lungs. Okay. All right. So here's another way to look at all that complex mechanism. Okay. So if you look in here, okay, look how big the amplitude is. All right. And look how small the amplitude is. Okay. And look how even smaller the amplitude is.
Yeah.
All right. So what we're trying to what I'm trying to show you on this one is that your amplitude starts huge, okay? But by the time you get to the alveolar area, it's very minimal. So that's why we're able to protect our alveolar units from over-distending. Okay.
Well, a lot of that has to do with ET too.
Correct.
Because in NICU,
So
most of the time they're too small.
So does anyone know what that terminology is called when we go from high pressure settings to low pressure settings?
Like attenuation.
There you go. Very nice, John. There you go. Attenuation. That means that you go from high settings, high pressure exposure, and as it travels down the ET tube, down the lungs to the smaller airways, it gets to the lower minimal settings. Okay? And that's why the high frequency, we can protect the lungs from over-distending, because at this area, even though this is cranking up super high, adults at 120 amp, by the time you get to the lungs, very minimal. Very, very minimal lung damage. So that's the safety factor that is built in.
And that's true whether you have it on high settings or low
Correct,
settings.
correct.
It's just the principle of the dynamic.
Correct.
Yeah.
All right.
You're like surprised.
Okay, so here we go.
Very
So,
smart.
It's the teacher.
so as John said the word of attenuation, let's talk about that, of the amplitude.
They made a slide for him.
Oh, look at that.
MD right there, did it even know?
John slide.
So, as you look here, okay, so this is the tip of the ET tube, and I related to the conventional ventilation of where we're at. So on the medium side of the tube, okay, at the distal end, okay, we got the proximal end, we have the boom, 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 that's been reduced. Now if you look at the conventional ventilation waveforms, it's still the same. Okay, that's what's so bad about conventional ventilation, is that the waveforms, the pressure exposure is all the same. As where for high frequency, the pressure exposure is very minimal to the alveolar units, where it's hardly anything. Okay, so that's why we're able to safely ventilate and oxygenate the patient. Okay. So, like I said, are there any disadvantages? Okay, so that's a question mark. So, that's up for grabs, yes and no. For neonates, okay, now utilize early intervention to prevent over distension and also potential lung damage, BPD. Okay, so that's what I'm saying. So, I mean, a lot of centers for the micropreemies, they get them, intubate the babies, and they'll put them on high frequency immediately. the newest trend for the last 10, 15 years is the Columbia effect, is where you intubate the babies and you extubate them immediately to a non-invasive cannula system like we use. And it works. But with that is that you're allowing the CO2 to climb up in the 70s, 80s, and 90s. Okay? We all freak out like, oh my gosh, that's too much. But remember, research. Okay? The goal here is to minimize. The babies in utero, okay, are not used to normal yet. They're abnormal. It's abnormal to be born at 24 weeks. It's abnormal to be born less than term. So since since the baby is born, well, all we're trying to do is trying to maintain its baby's homeostasis. So what is that? It's not 7.3 by 7.45.
Yeah.
Okay, that's term. That's life. That's independence. So in mom, they're more 7.25, 7.30, 7.28, 7.32. Their CO2 is not 35 to 45. It's actually more like 45 to 55. They're more hypoxic. They're more acidotic because their lungs don't have to survive. So if I ask you a question, what's better, an acidotic gas or an alkalotic gas? There you go. Because remember, our bodies are used to being in an acidotic state where we can conserve. But if our acid-base status is alkalotic, well, guess what? Our heart has barriers, the potassium and calcium channels. Okay, those are electrolytes. But what happens if my pH is 750, 760? It's gonna interrupt the cardiac, electrolyte function. So now you're gonna have arrhythmias, life-threatening. So it's always better to be on the acidotic side because we can conserve. The body shuts down. But if you're on the alkalotic side, the body doesn't know what to do. Okay?
20 years from now, that's what they're going to do.
Yeah.
Change the whole blood gases. This idea of giving adult settings to
Yeah.
adult values to infants is
Yeah.
ludicrous.
So another disadvantage is that because neonates we don't give paralytics, but adults we do. Okay? And one of the bad parts of paralytics is that you lose your muscle tone. When you lose your muscle tone, you lose the fluid regulation. So in the vessels, in the muscles, when it contracts, okay, it keeps the fluid in the vessels where it's supposed to be. But now, when we paralyze, okay, the muscles don't contract anymore. So we lose that that function. So fluid will leak out into the third space underneath the skin. So now you have these big puffy babies, big puffy patients, peds and adults. Now, what's going to happen to our blood pressure? Well, it's lower because all the fluid that's supposed to be in the vessels is leaked out to the third space. Okay, so now you got to give more fluids, more volume to maintain blood pressure. That's one of the hazards about why high frequency for those populations is not that good. And that's why APRD bilevel is a better way to go because we don't have to use paralytics. Okay, so we want them to breathe. So we just give them light sedation to the point where they don't pull the ET tube out, but we want them to breathe. And that's the whole case. Okay? So, but like I said, but this patient here that we had in ICU, the adult patient, he didn't qualify for bilevel APRD because his lung compliance was so stiff. Okay? Bilevel APRD, you still have to set up peak pressure control settings, high pressure, low pressure. If the lungs are too stiff, well then guess what? We're going to have to increase your pressure high to 30, 40, 50s in order to get the lungs to ventilate. And we don't want that. So that's the thing. So we have to base upon our decision, like when to use what high frequency bilevel based upon the lung compliance. If the lung compliance is normal, hey, let's go. We're in the early stages. We're going to increase our peak. Anything above 5, anything above 8. Okay, well, they're a candidate. Anything above 8, they're a candidate for bilevel. The earlier the better. But if they're already at 10, 15 and their lungs are stiff, when you're handbagging them, forget it. Don't even waste your time because you're going to max out your bilevel settings. Just go to high frequency, and that's why this patient was on it for about a week, Gloria. The patient up there in ICU West. Yeah.
Not a week,
Yeah.
3-4
3-4 days. Yeah.
Did the
3-4
patient
days.
survive?
Yeah.
Oh, wow, that's good.
Yeah. So 3-4 days. We convert him because his PO2 is like 40s, CO2 is 70s, 80s.
Lucky he was at sunset.
Yeah. So we got
He was
him back.
lucky enough,
Lucky he was
seriously.
at sunset.
Yeah.
Instead of somewhere else.
And this guy was a lung resection patient as well.
Wow.
Yeah.
Wow.
And that was the amazing part that he made that part.
Poor guy.
We're so scary.
The fact that he's out of
Is
there.
it only the peak that's an indicator for bilevel? Because sometimes the attendings in ICU, they use pressure control first and
Yeah.
then bi-level as a last
Yeah,
resort.
because they don't know.
Yeah.
So what are the parameters we look for?
So anything above 8, go on bi-level. And matter of fact, some hospitals on the East Coast, you know, it's like when they recover their patients from the OR, they put them on bi-level.
Peak of it greater.
Yeah, because normal people is anywhere between 5 to 6, 5 to 7 for physiologic. But but as we start increasing our peak, because we're losing our recruitment, we're also losing our oxygenation. Just want to switch them over.
You don't look at your mean air pressure?
Yeah, but remember, because your mean is a combination of your settings as well. So if my peak's at 8 and my rate's at 20, well, my mean's gonna be high. Okay? Because the amount of breath you're getting. Okay, the same thing, if my peak's at 8 and my rate's at 12 or 14, all right, and my patient's breathing 25 times a minute, well, my mean's gonna be high anyways. Because the patient's trying to compensate. You know, our body is very resourceful. When we need something, we're gonna do it. Okay? So if I increase my respiratory, that means that I'm air hungry, or I need more oxygen. So what's our natural reaction? Get more oxygen in. But nothing's gonna change. So that's why once you go above your normal baseline, especially your peak, that's the time to switch them over. So that's what I say, when I look at the preliminary event settings, if guys on a peak of 5 and a rate of 20, okay, and you have oxygenation problems, okay, that we really haven't optimized our mean yet. Remember that term, optimal mean, optimal peak. We really haven't. But if I see 8, 9, and 10, I'm like, okay, well, this guy's ready to go because we've done everything. He's on high FiO2s and a peak of 8, and he's still not improving because he still has collapsion of the lower airways. And in order to recruit it better, well, get them on some super levels of peak. How can we do that? Either with bi-level or with high frequency. Crank that puppy open, get those lungs re-expanded. Once they're re-expanded, then we can do whatever we want to the guy. Okay? As long as they're not pulmonary fibrosis or cystic fibrosis. Because those are diffusion capacity disorders. So that means that the AC membrane, no matter what we do, because it's so thick, oxygen won't diffuse across. So if you look at ARDS, all ARDS is a stiff lung disease. So the lungs are like concrete. So once we get those lungs re-expanded open, like a barge, okay? Now we're good to go because the AC membrane still functions normally. So asthma, emphysema, emphysema is a little different case, but still, so it's not really a diffusion capacity disorder. It's more of obstructive. So the two main ones is the cystic fibrosis and also pulmonary fibrosis. Okay. You guys ready yet? Stand up. Stand up. Stretch break. Stretch break.
I think
Stretch like that?
Go.
Is that stretch or stress?